So, like I was saying earlier, it is just almost inevitable that at some point there's going to be a hospitalization or an ER visit whenever we have a loved one that has dementia. It's frightening for everybody. It's disruptive for everybody. But there are some things that we can do to be prepared. And then there's some things that we can do if our loved one has to be admitted. And there's also some things that we can do if, God forbid, they have to have surgery. So we're really going to touch on those. This could easily be an hour, so I'm going to get going on it. So I hear from families all the time about horrible experiences that they had in the hospital because they assumed that because it was doctors and nurses that they were trained in memory care, that they were trained in dementia. It might have been a chapter in a class years ago. And so do not assume that just because somebody's a doctor, just because somebody's a nurse, that they know about dementia. They usually don't. Most of the time, you'll find you're the expert. And you can be very assertive without being disrespectful whenever you are talking to medical professionals. They are the experts in their field. You have become an expert in your loved one's health, and you have to be that advocate and be their voice. So hospitals and dementia really are not compatible. So you have to be more vigilant than ever. Now, one thing that we don't want to do is try to make a plan during a crisis. So I commend you on being on this program today, and I hope that if you have other people that can use it, that you will share it with them or have them get in touch with us, because we have to be prepared for the what ifs on this one. Because like we said, as this disease progresses, we know at some point they're going to start falling a lot. And that may very likely lead to a emergency room visit. Why are they going to start falling a lot? Because we haven't always been walking, and they're going to get to the point where they're not walking anymore. So just like when we learned to walk, we had a lot of falls. When we stop walking, we have a lot of falls. They're confused. They don't realize danger in the same way that they used to know danger. So some things to do now. And again, you're going to get these slides, so don't try to write all this down. One of the first things to do is to have one person that is your contact, and then that one person has your list of people so that you aren't trying to call 10 people. So if you just have one person, you call, we're on our way to the hospital, I need you to call everybody on the list. You prepare that list ahead of time with phone numbers, emails, that type thing. So you have your one go-to person. Another thing to do ahead of time is identify people who can sit with your loved one at the hospital, because we are not going to want to leave them alone. Even during COVID, even during the pandemic, there have been some instances where families have been allowed in because of their loved one's dementia. That is starting to ease up whenever our loved one does have dementia. So you can even have a doctor, and we're going to talk more about this in a minute. You can have a doctor write a note on a prescription pad for you in case you ever need this, that if your loved one ever has to be hospitalized, that you must be there with them, that you are their advocate, you are their voice, and that they have a dementia. So that's important because sometimes the emergency room staff doesn't get it or understand it either. And sometimes our loved ones compensate so well that they can fool anybody for a little while. Another thing to think ahead of time about is if you have pets, make sure that you've got somebody that can come over and take care of your pets, and that you always have a few days worth of food. That's not something you want to be trying to get together when you're in the middle of a crisis. Keeping all of your medication in one place, all of theirs and all of yours, so that if you do have to grab it and go, you can, and you're not running from room to room. And then making sure you have a hospital bag ready for your loved one and for yourself. And we're going to talk about what you need to have in that bag. The program that I used to do when I went into people's homes, that their loved ones were still at home, even encouraged people to have that bag already in the car for them to already have just a little, almost like a little overnight bag already in the car. So should we have to go to the emergency room, ask to ride an ambulance. Make sure whenever you make that 911 call that you're telling them on the call that your loved one has dementia. We need them to arrive without lights and sirens. because we're going to try to keep things as calm as possible, even if they're in the floor with a broken hip. We don't need lights and sirens and people running. So that's where you have to take some of those deep breaths. We're making the call and you're making them aware. My loved one has dementia. They've had a fall. Could you please come with no lights, no sirens? I will need to go in the ambulance with them. And again, you can be assertive, emphasizing that they have dementia and that they have a limited ability to communicate and that they might not be able to answer the questions correctly. So if they are in the ambulance and they're asking them, do you take any medications? And they say no, and that could interact with what they're about to give them. So just emphasizing, I have to be with them. You can also explain to the ambulance, around here it's usually MedStar, their triggers. And sometimes a person's trigger might be that exactly, with the lights or the sirens, that type thing. Insisting on staying with them, and then be prepared for a long wait. If they have to have surgery, make sure that you talk to the anesthesiologist and that you insist on the lowest possible dosage of anesthesia for the procedure. Sometimes they will tend to give them a different type of anesthesia because it's easier for them, it's easier on the doctors, on the nursing staff, on the medical team, but we have to emphasize that they have dementia. General anesthesia is the #1 accelerator of all dementias, especially with Alzheimer's. We know that it actually causes that plaque to start to multiply. We don't know why, but that's been something they've just figured out in the last few years. So if they have to have general anesthesia where they're intubated, they will come out from under that anesthesia at that next level of the disease. I've watched it over and over and over again. They can even do things like, somebody yesterday on support group was talking about their loved one had a knee replacement with a spinal block and a twilight. Didn't use general anesthesia, and a knee replacement is a big, deep, hard, long surgery. I just had one last year. So, and they did it without general anesthesia. That's amazing. So they do have other options. So really press for that. These are all the different kind of people that you're going to be talking to. So don't think that just because you've given your information to one person that it automatically is going to get to all these other people. You're going to be talking to multiple doctors. There should be a social worker, case worker, all different types of therapy coming in. There'll likely be a chaplain come in, a dietitian, multiple nurses. You may talk to a pharmacist, an anesthesiologist. You're going to have housekeeping coming in. Everybody who walks in the door needs to understand your loved one's conditions, abilities, and their limitations. So somebody needs to be there with them the entire time. Keeping in mind that many, many hospitals are understaffed, and somebody who has dementia, as you know, has to be watched continuously. So they have more needs than a regular patient does. Hospitals run on information, and a person with dementia is not able to provide reliable information about their medical history, because most of the time they don't even recognize pain in the same way that we would recognize pain. Their pain may come out as a challenging behavior rather than I have a headache. It might be I'm going to hit, I'm going to spit, I'm going to kick, but I'm furrowing my brow and I'm doing this, and my loved one knows that means I have a headache, but the nurse may think I'm having behaviors. And then we have to educate them. Hospitals also rely on protocols and rules, and a person with dementia doesn't really follow rules. So they can't recognize time, they can't control their behavior. Telling them, hey, it's 3 a.m., it's 3 p.m. doesn't mean anything. So this is how to be assertive whenever you need to with your communication, just things to remember, because we have to take the emotions out of it whenever we're trying to get a need met. So we're going to state our concern, state the information that supports the concern, suggest a course of action. And this may be where, because you know them, you might say something along the line of, you know what, maybe if I got up there in the bed with him while we were doing that IV, or if you'd go get some ice cream while we're have a plan, have an idea, recap why you think this might be the best option, keep it focused on your loved one, controlling your voice, not yelling or bullying, because we can get angry. Angry is that easy emotion, and then not making accusations or being disrespectful. It's really hard to do. So what can I do? Whenever your loved one's at the hospital, we're never, ever, ever going to want to leave them alone. Your doctor, like I said, can actually write an order for overnight visitors. You can stay, you can get other people to stay, you can hire people who've been trained in dementia and memory care to stay. You can have a rotation of siblings and children and friends and neighbors and church members. Please don't ever say, I don't want to be a burden to them. Give them that opportunity to serve you. Just like you enjoy being able to serve others, you feel good when you're able to help someone else. Allow other people to help. That's your support team that you need to have in place. They're going to be more confused than ever. They're in an environment that's overstimulating. There's strangers coming in and out, and so we don't want to leave them alone, because somebody's got to be their voice all the time. All of us have very likely had a hospital stay where they're coming in for blood draws, x-rays, catheters, transfers, you name it. It can be in the middle of the night. It could be all hours. They're not going to understand. They're also not going to remember to not pull out that catheter or not pull out that IV. What is this? Well, we may tell them over and over and over again, but that's not something they normally have. So we've got to be that advocate. Again, don't assume the staff knows about dementia. I let me move this where I can see my screen a little bit better. I had this happen where a family member told me the nurse came in, the nurse described what the call button was for. Her husband was being very pleasant and shaking his head yes. And she said, do you understand? Yes. He didn't have any idea but the nurse felt like he was, and even said to her, he's good, he can call me, you go ahead and. No, that's not understanding dementia. Of course she was giving him the answers. Do you understand now? Yes, I understand. Call buttons are useless to somebody with dementia. Again, we've got to have an advocate there to interpret their needs. So whenever somebody is in the hospital, dementia patients in hospitals experience more delirium, and we're going to talk specifically about delirium. They experience more falls, incontinence, pressure ulcers, pain, and inadequate food and fluid intake and sleep disturbances. And all of those can lead to challenging behaviors. So what are some things that you can do? We're going to provide you with 3 front and back pieces of paper. It will come in your email, and one of them is a medication list. 60% of all medication errors are caused by mistakes in communication. We're giving it to somebody verbally, and then they might give it to somebody. You've all played the telephone game where we're passing the story round and round and round, and it really gets out of control. So we want to have this written down. That's something that you have to update all the time. Be ready to provide the information over and over and over and over again. Because think about it. First, we're going to talk to the emergency room. Or first, we're going to talk to the 911. Then we're going to talk to the people that come to the house. Then we're going to talk to the emergency room. Then we're going to talk to the surgeons. Then we're going to talk to the people on the floor. We're going to talk all those different people. What if they end up going to a nursing facility? What if they're already in a nursing facility? What if they go to a rehab? We've got to be ready to say these things over and over, but if we have it on paper, we can hand it to them. And we've got these forms. All you have to do is fill them in. It's going to have their medications, their dosage levels, the doctor's names and numbers, their past hospitalizations, all their current conditions. Another thing, you're going to keep a notebook while you're there. This is going to be part of your kit, because you're going to want to track their pain. You're going to want to track their bowel movements. You're going to want to track everything that's going on with them. Every time a doctor comes in and makes a round, we're going to want to write down who was it and what was said. And then as you have questions arise, write it down. We all know how that is. Well, I'll ask him that when he comes in, and then they come in at 6 in the morning and we forget, or they woke us up. Every single time that medical information is transferred, there's a chance for a error. And I found this yesterday. On the average medical chart at the hospital, there's 5 errors. That's on the average chart. Now, what does that mean if average is 5? There's 10 and there's 0. The average is 5 because it's that information's being given over and over and over. So verify their records each time. Another thing we can do is to personalize that hospital experience as much as possible. As we're leaving, one of those things we want to take with us is a favorite blanket, a favorite pillow, favorite photos. You can have somebody make copies of photos so you can tape them up on the wall, having their favorite foods and drinks, if they're allowed. Limiting visitors, you don't want them just coming in and out, but you do want to have those people that your loved one trusts and is familiar with and feels comfortable with. So we want to make the hospital experience as familiar as we can. So these are some things that we can have packed ahead of time, or that we can have this list. And again, you're going to get this and you're going to get some list that you have in a bag ready to go. You need stuff for your own maintenance and comfort. You want to make sure that you've got some change. I've had people even go get a roll of quarters and just put a roll of quarters in there so that I can go get me a soda, or I can go get stuff out of a vending machine. Toothbrush, reading material, clothes, water, snacks. A cell phone charger is huge. Just buy a separate cell phone charger and put it in a bag. Your own hearing aids and glasses, your own medications, prescriptions, and over the counter. I've had folks even take like 2 days worth and put them in this bag so that if they have to go, they can just take it and go. You want to make sure and have a notebook and a pen, preferably a notebook that has pockets in it, so that as they're giving you information, you can stick it down in those pockets. A copy of your medical power of attorney. I should have put it on here. If you have something that is that shows that your loved one has dementia, and if you know what kind, that's good to have also, where you can go, hey, he has Alzheimer's. He's had it since 2012. I know what I'm talking about here. And then multiple copies of these papers we're going to give you, the personal health record and the hospital to home record. You'll want multiple copies of them, and you'll get those when you get this presentation. Other things that you can do is get to know the staff and call them by name, understanding that they've got a whole lot of other people that they're taking care of, as well as your loved one, being respectful of their time. Show them some appreciation. If you've got somebody coming up to visit, say, hey, could you go by and get some cookies for the nurses station here? Let's show them a little love. And then when you talk to them, this is just some ideas and then examples of what you can say. Hey, Susan, Dad will try to remove the IV. So if you would, could you please put some extra tape on there? Calling them by name, but telling them this might work a little better. Mike, my mom likes cranberry juice rather than orange juice. Doesn't sound like an order. I'm just letting you know. Denise, my aunt will need to eat more applesauce before she takes her medicine. That's just kind of what we do at home, and that's what works for us. Hey, thanks for doing that. Continuing to take those breaths so that you're staying calm, because you know that your loved one also is picking up on your tone. You may choose to tell them why you're there, but don't say over and over, remember you fell, remember you fell, remember I told you. We never want to use that word remember anyway. So that's kind of individual if you're going to. I personally did this last year when my mom was in the hospital. I was not using the word remember, but I would say in the same words over and over, and I had my whole family saying it over and over, because she was going, why in the hell are we even in here? Wasn't very happy. It's going, because you had a fall last night, because you had a fall. It was an accident. Yeah, we had a fall. Here's what, and just trying to stay calm, giving reassurances to them. You're okay. You're okay. We're okay. I'm here with you. That personal health record that we're going to give you a copy of, there's always that board that's in the room, and it usually has magnets on it, and you can actually put it up on that board. You can give it to them at the nurse's station. Ask visitors to bring you food and drinks to make sure that you're okay. Ask for a cot, ask for a recliner if you don't have it. Ask them about their delirium prevention plan. Hospitals have a delirium prevention plan because 50% of the time in older adults, 65 and older, they will develop hospital delirium. And this is not just dementia patients, but it's exaggerated in dementia. It's very, very common. What delirium is a state of worse than usual mental function brought on by illness or some kind of stress. A bout of delirium can actually make their dementia go into a progression to that next stage. Watched this happen again with my own mom last year whenever she had to have a hospital stay, and we had a bad bout of delirium. It can be missed by hospital staff because they don't know your loved one's normal, and so they may just think it's part of their disease. Now, keep in mind that not all delirium can be prevented, but there are things we can do to try to prevent it. That's why we are there. We're keeping an eye on them. Any subtle changes or things that we start seeing in their behavior, their demeanor, the way they're acting, put it in that notebook. 40% of delirium cases are preventable. So if we can stay on top of this and not just say, well, you know, they are in a different environment, maybe that's why they're acting. Write it down at 2 o'clock, whatever it is. Some hospitals have special units, especially bigger hospitals have units called ACE, Acute Care for Elders units or wings. And it's a special environment meant to minimize the stressors of a hospital stay. So you can ask if the hospital has an ACE unit. Another thing we want to do is we want to minimize sleep deprivation for our loved one. Again, if you've ever been in the hospital, you know they come in all hours, day and night. So you may ask ahead of time, would it please be possible? Is it necessary that you come in and do their blood pressure every hour? Or is that just a normal protocol? And could we maybe not do it for my dad or my husband? And the doctor might have to write an order to say, you know what, we don't have to get their blood pressure all night long because we need them to sleep. Don't ask for additional sleep aids. This can actually increase the risk for delirium, but if they already take a sleep aid, we want to make sure that they get it. Use music, use massage, use tea, use companionship instead. We want to minimize their vision and hearing impairment, so we want to make sure they have their glasses and their hearing aids and keep things as simple as possible. We want to make sure and encourage some physical activity while they're in the hospital. If they don't already have a physical therapist coming in and it's not already ordered, we could ask for it. You can ask, could we get a physical therapist in here? Because being bedbound can trigger delirium in anybody. Also, minimizing pain and discomfort. Watch for pain and watch for constipation and bring it up to the doctors. And remind them that just because they say to your loved one, are you hurting? They may very well say no, but you know them best. You know how to read their body, and you can say, actually, yeah, they are. Here's why, I can tell. How do they treat delirium and what triggers it? Pain, untreated pain can trigger it, a UTI, constipation. Oh, I've got pain on there twice. Must be important. Not having their glasses or their hearing aids, medication side effects. They may start giving them medicine they don't normally take. But if they treat an issue, if they treat the pain, sometimes the delirium will go away. So we need a calm environment. And then the other thing is, if they get to the point that they're trying to injure themselves or injure other people, they will turn to restraints, and they can restrain in the hospital. They can chemically restrain, which means they restrain with medication, or they can physically restrain them, which means that they can, I hate to say tie to the bed, but it is kind of tying to the bed. It's done with Velcro, but it is tying them to the bed. So if they do become delirious, it can be very, very scary to see them acting this way. So we have to try not to panic. Focus on doing what you can to ease their comfort. It can take days or weeks for them to get better. So my mom's delirium last year, they told me they were going to restrain her. I told them they were not going to restrain her. We will get this under control. My daughter got in the bed with her, and she laid up in the bed with her grandma. And my mother bit a hole in her arm, bit a chunk out of her arm while she was laying in the bed with her. We still didn't have to get her restrained. We were able to talk her down by using music, putting on TV show that she liked, staying very present and very close to her. We did end up having to use some medicine, but we didn't have to knock her out. It wasn't a good experience, and she never fully recovered from it. But it's one of those things, just to be aware that it can happen, and it's pretty common. So things to ask, and I know we're right at time, so I'm going to try to hurry and get through the discharge. Get the name and number of the discharge planner and their office, the case manager. You always have access to a social worker. They may not always tell you that, but you can ask for their social worker or their discharge planner. You can also ask for a patient advocate. Hospitals have what's called patient advocates that can help you if you don't feel like they're hearing you. You can find out what's covered by Medicaid, Medicare, VA insurance, that type of thing. They can also provide transportation for you. If you're going, I don't know how I'm going to get them home. I don't know how I'm going to get them back to the facility. I don't know how I'm going to get them to the rehab hospital. That's what the social worker's there for. You want to make sure that you are present at discharge and that you've got all your questions answered. Don't leave there until you have your questions answered. Share your concerns with the discharge planner. There's always a discharge planner. Many times it is a social worker. Sometimes it's a nurse. You may go home with professional in-home care. You may go home with rehab, especially if you're needing additional help, but you have to know to ask for it sometimes. Again, we're going to give you a copy of what's called a hospital to home record, and it's going to have a place for you to write in there follow-up appointments, medications, changes in diet, new procedures, new equipment. All of that stuff's going to be on the papers that we're going to get you. After you leave the hospital, you're going to want to make sure and follow up with your appointments. And when you go to those appointments, take that notebook that you had in the hospital with you, because your regular primary care physician may not even know anything about them being in the hospital. So you're going to, and they may have changed their medications up. You're going to want to take that. I also have found it beneficial to call ahead of time when you're making that follow-up appointment and go, hey, we've had a hospital stay, so this is probably going to be a little bit longer visit, so that they will schedule a little bit longer time. Medication management is priority. The number one reason people return to the hospital in a real short amount of time is because of mismanagement of medication. So make sure that you have got a pill box that has a compartment for each dose each day. Instead of just putting all of Monday in there together, you've got the Monday at 10, 2, 6, and 10, you know, whatever it is. You can get them very, very specific to that. These are the three attachments you're going to get. You're going to get hospital to home, personal health record, and preventing medication mistakes. They're both a front and a back. So please make sure you open those, and you are welcome to share those. Those are from our friends at the Rosalind Carter Institute. There's our information. Let me stop sharing. I see we do have some questions. I appreciate y'all being patient. Let's see. So yes, your primary care physician should make a note of their dementia in their chart, but how can you be certain that it's in there? That's one of those things that you can ask. You can actually come out and ask, hey, I want to make sure that this is in their chart, that they have dementia, because almost just in case we have a trip, it's just about inevitable that we're going to have a trip. So asking that it is noted. Oh, great idea, Judy. That's a good idea. She was talking about, you know, producing some type of a booklet that family members can have to take to the hospital. These forms you're going to get are probably going to answer the majority of that. They're very thorough. Is it important to note the amount and consistency of the bowel movement? Yes. If you see that, if you have the chance to write that down, because sometimes that change is something that's really important. Oh yeah, this easily could be, this could be one of our lunch and learns. This could be an hour easy. It could probably even be 90 minutes. I appreciate all of y'all's time. Does anybody have any other questions? And like I said, you're going to get this. And if you have other questions that come up, you know how to holler at us.
I have a quick question about what you said. You could actually hire a caregiver to sit with them at night. Like
Can.
my mother was in the hospital during COVID. They wouldn't let us in for 12 days alone. And they probably wouldn't have let a caregiver in. I didn't think of that. But I guess we're kind of talking non-COVID, right? Like even
Yeah.
they wouldn't take a doctor's prescription right now to let another person in because of COVID, right?
I don't know about right now. They very well might now, especially if it was somebody that you hired that was a medical professional that had been vaccinated, because the majority of the places, I'm looking at our friends across the street here, Visiting Angels. I just looked right at them.
Yeah, that's who I was thinking about.
Those type places, the majority of that staff is likely going to be vaccinated, and many of them have been trained. And those with a doctor's note, they may very well be able to get in now.
Yes, this was December over Christmas when she was in, but right now it's a different world, even in 3 months.
Now, yep. Yeah, that threw us for a loop there last year.
Yeah.
I know when Mildred was in the hospital, they didn't want me to stay, but the doctor called me at 2:00 in the morning and said they couldn't do anything with her. How soon could I get up there?
Yep. It gets bad enough, they'll let you in.
Yeah. So I ended up staying the whole week with her night and day. So it was more than they wanted to deal with.
And that's also as you go in and you're being honest and you're being their advocate, you now can even say, Cynthia, hey, listen, here's what we had happen before. I'm trying to make your life easier too. I'm trying to make your life easier. I'm trying to make my loved one's life easier. I'm trying to make my life easier. Please trust me when I tell you I know them.
You would think the nurses would appreciate the extra help.
You would.
Holly, when Boyd was in the hospital back in 19, they hired a sitter to stay with him. And I didn't even know they were doing it till I got there. I was wondering if you knew the circumstances under which that might happen.
I don't. Jamie, have you experienced that, or the hospital actually? Now, I have had hospital have volunteers go in before. I've had them have volunteers go in until the family could make arrangements, but I don't know that I've heard of a hospital hiring.
She was there at least 2 or 3 days, and I was never charged for it. I mean, it went through insurance, I guess. So I don't know.
Very good.
Holly, I could add just a little bit. If an individual in a hospital has one-to-one needs, potential of harm to self or others, not suicide necessarily, just they could harm themselves or others, then the hospital is obligated to provide them a level of supervision. And that is often a one-to-one. It will be probably with a non-licensed caregiver, an aide, and that's not charged to the individual as long as the person meets that criteria. And they have to evaluate them at least several times a day to see if they're still in that, that they need that level of care.
Very good. Thank you.
Baylor All Saints hired one for my husband a year ago, February, when he had a pacemaker put in, and the pacemaker was actually inserted directly into the heart, not under the skin. And because the entry point was at the groin, he had to lie flat for like eight hours. And so I stayed there overnight with him, but they did hire somebody, an aide, to be there because he kept trying to pull the bandaging away, and eventually he did stop that. But there was somebody there 24 hours while he was there.
Very good. Thank y'all for sharing that. That's why I say y'all are the experts. I appreciate it. And Kay, thank you for sharing that. So, and it's some of that, once you know it, you can also then ask for it, and you can kind of go in, especially if it's a scheduled procedure and you've got a little more time than if it's an emergency. But like I said, we'll get this over to you. I appreciate y'all hanging with us. We're about 10 minutes over, and I want to respect your time. And again, if you think of anything else, holler at us. We'll get this out to you today. And again, please, this is just such important information. Feel free to make copies of those forms.
Thank you.
Thank you.
Thank you.
See y'all soon.